and from 2010 until 2016 served as fellow representative on the Council of the Royal College of Obstetrics and Gynecology. The topic of his presentation today is the Chamber of Secrets, Indicator for Embryo Transfer Success. So please, Charles, the floor is yours.
Thank you very much, Zev, and hello, everybody. Could I first of all thank the organisers for inviting me to this virtual meeting today. It seems strange that we're still in 2021 meeting virtually, but any port in a storm. So thank you very much again for the organisers. I want to talk a little bit about something that's very dear to my heart, and that is the technique of embryo transfer. So technically easy to do, but so difficult to be successful with. And I've used the analogy with Harry Potter, as those of Harry Potter fans will probably have already deduced, that I consider this technique as a little bit about putting the embryo into a chamber of secrets. What I want to do is to try and demystify some of those secrets and just share best of my own personal tips as to how we can optimize the embryo transfer performance and do the best we can for our patients. So this is where it all began for me 30 years ago. I was a research fellow working with Robert Edwards at Bourne Hall and also Howard Jacobs at the University of Middlesex in the late 90s. I actually joined Bourne Hall in March 1989, and Patrick Steptoe sadly died a week later. I hope it wasn't cause and effect, but he had been ill for some time after that. But I continued working there, and I spent some very valuable time with Robert Edwards when Bourne Hall was undergoing a period of transition. I had the great privilege of being one of the doctors there performing embryo transfers with Robert as the embryologist. So the procedure of embryo transfer is of vital importance for a successful outcome after IVF treatment. Nowadays, we create these magnificent euploid embryos, yet we still are reliant heavily on the final stage of the procedure to ensure that we achieve the best we can in terms of pregnancy outcomes. Therefore, a careful and atraumatic embryo transfer in a skilled and experienced hands can maximize the chance of embryo transfer. I just want to briefly touch on embryology. I'm not an embryologist and I don't claim to be a scientist. However, one of the things that I am quite keen on is the amount of volume of fluid that's placed in the embryo transfer catheter before it's handed over to me to replace the embryo. And I often, we have this conflicting debate with the embryologist. I always say I'd like a little bit of volume so I can feel the plunger move, and then some embryologists are quite willing to do that, whereas others say no, we should have a small amount as possible because that improves success. Well, there's no reported difference in pregnancy rates if loading from drops under oil or rinsing the tip before transfer. Pre-warming the catheter is not recommended, as the tip will be ambient within seconds, and heating may increase VOC release. And there's no clear evidence that flushing the catheter before loading embryos improves outcomes, although most labs do. High hyaluronic acid content appears to be beneficial, suggested possible benefits of increased viscosity. However, higher protein concentrations within the culture medium do not improve outcomes. There are, in terms of volume, there are few randomized controlled trials or prospective studies, although one study did show better outcomes when using 40 to 50 microliters compared with a smaller volume of 15 to 20. So it would appear that the volume of fluid within the catheter at the time of embryo transfer doesn't appear to make much difference. Neither do the air gaps that are placed between the embryo and the outside world in the catheter. So air in the transfer catheter does not of embryo transfer. So we come to the technique. We've loaded the catheter and we're now preparing the cervix. What I like to do myself is to fix the cervix as carefully as possible between the blades of the cusco-speculum so that we can get a clear view straight into the cervix. Now, what I'm going to do now is I'm going to use data that's been published between the Human Fertilization and Embryology Authority, our regulatory authority in the United Kingdom, and the guidelines that were published in 2017, entitled Performing the Embryo Transfer, a Guideline. This was published by the Practice Committee of the American Society of Reproductive Medicine. I'm also going to use the NICE guidelines, the National Institute of Clinical Excellence guidelines, that were last revised for assisted conception in 2017. So with regard to cervical mucus, the guidelines suggest that there is benefit in removing the external cervical mucus from the cervix prior to embryo transfer, although there is little benefit in removing that thinner mucus within the cervical canal. This is grade B evidence from the American Society, grade A being the best, as published following randomized prospective controlled trial. So grade A evidence is the best. Grade B is fair evidence to suggest that it's of benefit, whereas grade C has been categorized as insufficient evidence or no evidence at all to suggest a benefit. So by removing carefully the external os cervical mucus, there is grade B evidence to suggest that this is of benefit in terms of pregnancy outcomes. What about selecting the right type of embryo transfer catheter? Again, there is grade A evidence to suggest that flexible catheters are of benefit over and above more rigid types of catheters. At Care Fertility, we tend to use Wallace catheters. I was brought up with Wallace, Harry Wallace being a personal friend of Robert Edwards, and he developed the first embryo transfer catheter to be used at Bourne Hall. We've been using that ever since, and this is the catheter I train my junior colleagues with. Not that there aren't other catheters widely available, but we use the flexible embryo transfer catheter from Cooper Surgical. So we've removed the cervical mucus, we've got our volume of fluid in the catheter, and now we have chosen a flexible catheter. How we're going to negotiate the cervix and place our embryo into the uterine catheter. So there is clear evidence now that using ultrasound guidance to help negotiate the catheter into the endometrial cavity is of undoubted benefit. There have been debates over the last few decades. I've been involved in some of them about using a no-touch technique or ultrasound guidance, and I often speak to colleagues who say, well, I've done many thousands of embryo transfers, I can feel my way in, and I do not need to resort to ultrasound guidance. I liken that really to eating your dinner in the dark. Why would you eat your dinner in the dark, although you know where the plate is, you know where your knife and fork is, when you could turn the light on and actually see what you're doing? I'm unsure of any other techniques that we can do in gynecology where direct vision is not of benefit. So lots of units now utilize transabdominal guided embryo transfers. Some units, as I said before, use touch technique only. There are new innovations now. Really, you can get really great pictures of 4D ultrasound guided embryo transfers. No evidence to suggest that they're of any benefit at the moment. We tend to assess the placement of the embryo in 3 planes for accurate deposition. And here's a 2D standard ultrasound guided transabdominal approach. You can see quite clearly on the right hand side the catheter, and nowadays we can have ultrasonically visible catheters. You can see the endometrial cavity very well and place your embryo accordingly. Ultrasound guidance facilitates the entrance of soft catheters into the uterine cavity. It confirms that the catheter is located past the inner opening of the cervix. It facilitates the direction of the catheter inside the uterine cavity, avoiding trauma. We tend to use a fuller bladder, which aligns the uterus, giving a clearer ultrasound image. And of course, finally, you can visualize exactly the location for depositing the embryos, which not only is a benefit to you, the practitioner, but it's a benefit to the patient themselves, because it's great for them and reassuring for them when they can actually see the embryo being deposited within the uterine cavity. And indeed, the National Institute of Clinical Excellence in the United Kingdom, the guidelines revised in 2017, suggested that women undergoing IVF treatment should be offered ultrasound guided embryo transfers because it improves pregnancy rates. We tend to use this maximum implantation potential that was a paper published many years ago now, 2005, but we tend to put the embryo 1 centimeter from the fundus and use this maximum implantation point as the bifurcation between the 2 tubal ostia and the uterine fundus, 1 centimeter from the uterine fundus. Now, one of the things that I used to always do was to, once I'd found my maximum implantation point under ultrasound guidance, I used to carefully press the plunger and deposit the embryo 1 centimeter from the uterine fundus, and then wait 20 to 30 seconds, because I had this vision that the embryo was gently floating away and it had time to sort of equilibrate. However, the ASRM guidelines tend to differ, and there is fair evidence to suggest that immediate removal of the embryo transfer catheter is of benefit. So now my practice has changed so that once the embryo is deposited and you press the plunger, you've seen the flash on the ultrasound guidance, I would immediately remove the catheter as quickly and as atraumatically as possible from the endometrial cavity. Going back to those early days in the late 1980s, following embryo transfer at Bourne Hall, we used to have patients lying in the head down position as inpatients for 48 hours after embryo transfer. And I can remember quite well doing ward rounds with Professor Edwards, and we'd see patients 24, 48 hours after embryo transfer, ask them how they were feeling. Most of them said they had a headache, and most of them had been lying there with their head down. And now, of course, we know that this is of no benefit if you don't want to give a patient a headache. Similarly, there is now plenty of evidence to suggest that early ambulation is of benefit. So we get our patients to immediately after embryo transfer to mobilize. Of course, some patients would like to lie there for 5-10 minutes, and that's absolutely fine, but there is no clear benefit in getting patients to lie down, and certainly not in the head down position, because that's actually counterintuitive, isn't it, from the law of physics? The embryo, as you lie down, the embryo floats upwards. So if you stand up, then the embryo will float further up into the uterine cavity. The human factor. Does the operator performing the embryo transfer significantly impact on outcome? Well, that's a no-brainer. Yes, the answer, that's been proven conclusively that the more you do, the better you get. And here's Dustin Johnson winning the British Open a couple of years ago. He might have the best equipment, as I like to think I do, but it doesn't make you any better just because you've got a flexible catheter that's been loaded as carefully, and you've got ultrasound guidance. You've still got to put it in there, and practice makes perfect. The more you do, the better you get. Difficult transfers. Well, I would suggest that there is no such thing as a difficult embryo transfer. The vast majority of embryo transfers which you perceive to be difficult should have been anticipated well in advance by taking a good history, and also in cases where you think there is a high risk of a difficult transfer, practicing doing a dummy embryo transfer in the early follicular phase of that particular cycle. I know that's open to debate, and I know that some people would say that could be misleading, but there is nothing better than anticipating the difficult transfer so that you can get over that difficult conversation with a patient who has failed to get pregnant as to why did the doctor take so long, why was it so difficult. Anticipate by taking a good history and then practicing if you need to. So what have I learned from my trawl of the American Society of Reproductive Medicine guidelines, the NICE guidelines, the Human Fertilization and Embryology Authority guidance, and also my own personal experience? Well, grade A evidence when it comes to performing your embryo transfer. Use ultrasound guidance. Use a soft embryo transfer catheter. No need for bed rest. In fact, no bed rest. Grade B. Acupuncture is a little benefit. I'll come on to that again just in my summary. We do not need antibiotics. I know I haven't covered these in the talk, but I'll just throw these in at the very end. Acupuncture is of little benefit. And antibiotics, there have only been one randomized controlled trial which failed to prove a benefit from the routine use of prophylactic antibiotics prior. So has no effect on outcome. So what are the myths? Unfortunately or fortunately, we love, as humans, we love a good story. We love the legends, the myths, the superstitions, and a lot of our medicine is based on it. Certainly, you could say the majority of it was based on these sort of non-evidence-based aspects of treatment until the onset of or the development of evidence-based medicine, as you know, as early as 30 years ago. But there are, and you know, sometimes there's nothing wrong with myths. It's like you know, massage therapy. As long as it's not harmful, why not? As long as the patient is fully informed as to the risks and benefits, then we are at you know, liberty to choose what we think is best for us, as long as, I say, it's not harmful. And that can also mean I include financially harmful as well, because similarly, there is no point in doing any treatment if that it is expensive and of no proven benefit. Again, though, if the patient wishes to subject themselves to increased costs, even though they are aware it's of no benefit, then there is a debate as to whether the patient should be allowed to do this. I mean, I was born and bred in a city in Britain called Nottingham, and I certainly believe in Robin Hood. So, what are the myths? Acupuncture, analgesics and massage, prophylactic antibiotics, expulsion speed, and waiting after expulsion of those embryos. These are myths that have been disproven to be of no benefit, but not necessarily harmful to the overall outcome of embryo transfer. So, the prologue of the Chamber of Secrets. What would I suggest when doing your embryo transfer? Do it under ultrasound guidance. Remove cervical mucus. Place the embryo under ultrasound guidance 1 centimeter from the uterine fundus at the maximum implantation point. Immediately withdraw your embryo transfer catheter and get the patient to ambulate early. Thank you very much.
Thank you, Charles, for a very exciting and profound review. I have very few questions for you. Are you giving routine antibiotics at the time of egg collection?
No, we don't actually, Zev. We would only give routine prophylactic antibiotics if there was a past history of severe pelvic infection or endometriosis, or indeed presence of an endometrioma where there is an increased risk of infection. From a medico-legal standpoint, if I get a lot of requests to offer my advice regarding infection at the time of egg collection, and it almost is always associated with endometriomas or cysts that have been inadvertently punctured at the time of oocyte retrieval in the presence of an endometrioma. So these are the times when I would offer prophylactic antibiotics, history suggestive PID, previous pelvic infection, or the presence of an endometrioma.
I agree with you that embryo transfer is a very, very important part of the IVF procedure. So what do you think about using dummy catheter in all transfers? Not when you think there is difficulties.
Using what, sorry?
Dummy catheter in all transfers. Mon catheter, you know, put a catheter into the uterus and replace only the inner part with the embryos.
Well, I think yes. I think that's something that we should be seriously considering now. Yeah, we have a debate as to who should be putting the embryos back, and I think there's a strong case now for the gynecologist to place the nurse practitioner to place the outer catheter into the correct position, and then the embryologist to thread the catheter, the inner catheter, through the outer sheath into the position it should be in. This is something that we've been introducing, but it's certainly not widely popular, or there is some reluctance, as well as enthusiasm by embryologists to put the embryos. Do I think it's a good idea? I think on balance, yeah, I think the future is a two-step technique, so that you actually are confident that the embryo, as soon as it's put into the outer sheath, is going to end up in the place you want it to end up, and which is 1 centimeter from the uterine fundus at the point of maximum implantation potential.
And the last question, have you looked at the time interval between loading the catheter to the transfer?
There's not a lot of data on that, although it's fairly self-evident that you want to keep the embryos as warm as possible, so that if there is a circumstance where the embryo transfer is difficult, and there's a time lapse between loading the catheter and then placing the embryo, or at a time when the embryo needs to be returned to the embryologist because you're just having difficulty, I think it's useful to keep the embryo warm. But I'm not aware of any specific data, other than the obvious, to suggest that there's any time importance between at what point should you replace the embryo back into the incubator if it's been out for a particularly long time. Although intuitively you've got to, it needs to be into the uterine cavity as quickly as possible after it's been removed from the incubator.
Thank you, Charles. I think we have to stop here and to move onwards with the program. So thank you again for being with us today.
Pleasure. Thank you, everybody.
It gives me the greatest delight to introduce Dr. Alison Campbell.